Hello and welcome to Course 2, the coding portion of the training for HOPE implementation. A Hospice Outcomes in Patient Evaluation, or HOPE, is the new hospice data collection tool. This coding workshop is a follow-up to the recorded virtual didactic training series posted in July by CMS. The didactic series is the foundation upon which this coding workshop was created. Taken together, this two-part series will prepare you and your team for the national implementation of HOPE. If you have not viewed the didactic training, we strongly encourage you to do so. The disclaimer just explains that the information included was current at the time it was published or uploaded onto the web. Medicare policy changes frequently, so links to the source documents have been provided within this presentation for reference. These may include links to statutes, regulations, or other policy materials. The intent of this presentation is to be a general summary and does not take place of either the written law or regulations. We encourage participants to review all current materials related to HOPE. Before we proceed with today's training, we have a few housekeeping items to review. This event is being recorded. The recording, transcript, and slides will be published following the event. Attendees will be directed to these resources once available. If you have any questions about content being presented today, please use the Q&A feature found in your Zoom meeting toolbar, typically located at the bottom of your screen, and the team will review. If you need technical assistance or have any comments you would like to share, you may use the chat feature. Now, you may notice closed captioning is enabled for today's meeting. You can customize closed captioning in the Accessibility tab of your Zoom settings. If you prefer to turn them off, you can click the Hide Captions icon in the toolbar at the bottom of your Zoom window. Lastly, we ask that you please complete the short survey, which will be available at the end of the event in your web browser. Your feedback is important to us as it helps us shape future events to support your needs. Now I will turn it over to Zinnia Harrison to begin the training.
Thank you, Alana. Hello, I'm Zinnia Harrison, a principal associate with over 23 years of health program and policy experience. My expertise is in hospice Medicare regulations and hospice policy development. I have worked with CMS on the Hospice Quality Reporting Program and HOPE for the past 6 years while at APT. Our presenters today will be Brenda Karkos, a hospice nurse and hospice administrator. She is now a senior associate at APT Global. Terry Mata is an RN and an associate nurse researcher at APT. Teresa Rada is a physical therapist and also a senior associate at APT. You'll hear a bit more about them when they introduce themselves before their sections. During this training, we will review each section of HOPE. So Section A, Administrative Information, Section F, Preferences, Section I, Active Diagnoses, Section J, Health Conditions, Section M, Skin Conditions, Section N, Medications, Section Z, Record Administration. I anticipate at least one break, possibly two. So we'll provide more important information in the resources throughout the workshop and in the chat and at the end. There will be a brief Q&A session that includes questions we've previously received since the didactic training posted in July. If you have questions during the workshop, please submit them in the Q&A feature Alana just shared. But these will be forwarded to CMS for review and may be included in a future FAQ document. At the end of today's webinar, you should be able to briefly describe the HOPE tool and the plan for its implementation, discuss at least 5 items that have been added to the section for HOPE hospice data collection, identify key concepts for collecting HOPE data, explain the symptom impact and HOPE symptom follow-up visits, or SFV, list 3 resources to learn more about HOPE. We just got you started with some links in the chat, and if you were reviewing the didactic training, it was also there. There are many acronyms used throughout today's presentation, including ones related to HOPE. The link on the slide will bring you to a list of common acronyms used in the Hospice Quality Reporting Program. This will be an interactive workshop with polling, so let's get started with a couple of questions to know who's joined us today. These questions and all polling results will be collected anonymously to get a better idea of attendee experience and knowledge. So please take a moment to respond to how often you access the HQRP web pages. Okay, let's go to the next slide and poll. So let's take a moment to let us know who's attending. How long have you been in your current role in a hospice setting? Now, if you're taking this training with a team or a group of teammates, find out who has the most years of experience in the current role and then submit that as a collective response. So it does look like there are some folks that have been working in the hospice field for quite a while, and then some that are brand new. Hope is brand new to everyone, actually. So even those with decades or more of experience, we are all learning today. Okay, so we'll start with an overview. Hope is the new data collection tool for hospices starting on October 1st of this year, 2025. Hope will replace the Hospice Item Set, or the HIS as you might know it, and it's finalized in the fiscal year 2025 Hospice Wage Index Final Rule. Hope will also add new items or assessment-based quality data to enhance HQRP. This will be accomplished through standardized data collection. It will provide better understanding of patient care needs, contribute to the patient's plan of care, and provide additional clinical data that could inform future payment refinements. There is a link on this slide for the hospice final rule, as well as this and many other links in the resources slide. Here's a list of the different sections of HOPE. We have noted in red the sections that have new items or were expanded, as well as the one new section, Section M, which contains 3 new items related to skin conditions. So Section A has some new and modified HIS items. Section F, preferences, is entirely unchanged from HIS. Section I, active diagnoses, has an expanded list and comorbidities. Section J has both new and modified items from HIS. Section N, skin conditions, is all new. Section N is unchanged from HIS, and Section Z has 1 new item. So today, you are attending Course 2 to learn how to code the HOPE items. So Course 1, as mentioned before, is a didactic recorded training series that was released by CMS in July and is located on the HQRP Training and Education page. The recording from today's session will also be available on the HQRP Training and Education Library. The link to the training page is located on the slide as well as in the resources slide. Although it is best to review Course 1 prior to taking Course 2, please do stay for Course 2 today, but make a commitment to review Course 1 in the next day or so. So now I will turn it over to Brenda Carcos to share a little bit about herself and then discuss Section A.
Okay, thanks, Zinnia. So I'm Brenda Carcass, and as Zinnia mentioned, I am an RN with many years of clinical and administrative experience, including inpatient, community health, hospice, and oncology. I do currently serve on the board of directors for Hospice and Palliative Care Federation of Massachusetts. And since joining APT in 2016, I've contributed mostly to CMS projects focused on hospice, oncology, home health, and other post-acute care settings. As the hospice subject matter expert, I've been fortunate to be able to contribute to the development of HOPE. So now let's walk through the Section A administrative information items. So here's a screenshot of A0050 type of record. This item is unchanged and is included in each HOPE submission for all 4 time points. This is just that the record is being submitted, and whether it's a new record, a modification to an existing record, or perhaps the inactivation of a record that needs to be withdrawn because there was some error. So for coding instructions, when your hospice is submitting, they indicate the type of record that's being added. So you code 1 if it's a new record. It hasn't been previously submitted to the system. You would code 2 to modify an existing record if this is to request a change for something that you already had submitted and was accepted. And you would code 3 to inactivate an existing record if you needed to inactivate a record because something you submitted was in error. So here's an important definition. A modification request is used when a HOPE record has been previously submitted and accepted in the system, but the record contains clinical or non-key demographic errors. This might be something like a response on a single item, a clinical item that needs to be corrected. And here's a definition of the inactivation request. So this is when a record that's been previously submitted and accepted, but particular item values are inaccurate. So there are two types that are important for inactivation. One of them is the record identifier. If any of these are wrong, the record would need to be inactivated and resubmitted. And these include things like the admission date, the reason for the record, the discharge date, and a new item, the date assessment was completed. The other category is the patient identifier, and this includes the first name, a last name, if a social security number or the sex of the patient was wrong, or perhaps a date of birth. And if any of those are wrong, they would need to be inactivated in order to submit a brand new record. So here are a few coding tips for the type of record. Corrections should be made to any records that have errors to ensure that the information is accurate and reflects the patient's identification, location, and the reason for the record. So keep in mind that the system will reject duplicate records when submitted. If there is a fatal error, this will be reported to the provider on a form called the Final Validation Report, or the FVR. And anyone in your office that currently submits these records would know what that is. And generally, though, a modification request can be used to correct most errors. So here is a screenshot of facility provider numbers, which is also an item that is unchanged. It will be included in the HOPE submission for all 4 time points. The facility provider numbers will identify the National Provider ID and the CMS certification number, or the CCN, and that lets CMS know which hospice this is. So A0215 is the site of service at admission, and this identifies where the patient is receiving services at the time of the admission. There are 9 choices, and if the patient is perhaps in a location that is not on the list, you would mark 99 not listed. The response choices for this item have been slightly revised for HOPE. And here are a few coding tips for this item. The codes are structured to match sites of service found on Medicare claims. And for the purpose of completing this item, the term SNF is not synonymous with nursing facility. If a beneficiary is in a nursing facility but does not meet the SNF criteria, you would code Nursing Long-Term Care, or LTC, also known as NF, or Non-Skilled Nursing Facility. So let's look at some of the date items. Here's the admission and the discharge dates. Neither of these have changed for HOPE. The admission date will be submitted with any completed record, including both the new HOPE update visits. And that is because it's used for record matching to be sure that all the records identify the correct patient when submitted to CMS. The discharge date is also unchanged and will be submitted with any discharged record. And here are a few coding tips. First, you would enter the date the patient was admitted or discharged from hospice, whether or not a return is anticipated. Don't leave any blank spaces. If the patient expired, the date of death is the discharge date. And for live discharges, it's the date the patient revoked the hospice benefit or the date the hospice discharged the patient. Now here's a screenshot of the birth date. And this is also not a new item. It will be submitted with any completed record, including both HUV records. It is also used for record matching to be sure that all the records identify the correct patient. Some tips about the birth date. In case part of the patient's birth date is unknown, there can be circumstances where only a birth year is known, and in that case, you would just enter the year and leave the month and day boxes blank. If the birth year and the birth month are known, but not the birth day, you would enter the year and the month and just leave the day boxes blank. So A0250, reason for record, is used to identify which record is being submitted, whether it is the admission or one of the HUVs or the discharge. This item is marked revised only because the options for the 2 new HUV time points have now been added. And here are some of the coding tips for this item. An admission and discharge record must be completed for each patient admission to hospice. However, depending on the patient's length of stay, up to 2 HUV records may be required for each hospice admission. CMS expects that the number of HUV records will vary since the length of stay in hospice can vary greatly. Now, this is the legal name of the patient and another item that is unchanged and will now be collected on all of the HOPE time points. Let's go over a few of the coding instructions for the legal name. This is the patient's name as it appears on their Medicare card. If the patient is not enrolled in the Medicare program, use the patient's name as it appears on a Medicaid card or another government-issued document. And for a middle name or middle initial, if the patient has no middle name, you would leave it blank. If they have 2 or more middle names, you would use the initial for the first middle name. And for the suffix, if there is no suffix, you just leave it blank. And a few more coding tips. Carefully check the spelling of the patient's name when submitting this information, since any typographical error in the patient's name may cause a new record to be created for the same patient during submission. Now let's look at the zip code. This is another Section 8 item that is unchanged. This item is only collected on admission. And here are just a few coding instructions for the zip code. This is the address where the patient is residing while they're receiving hospice services, even if it is not the patient's usual legal address. You'll always start with the leftmost box, even if you don't know the last 4 extended numbers. Care Compare uses this zip code to determine the location where your hospice has been providing services. Now, on this slide, there's an example in the yellow box. The patient lives in City A but is currently receiving hospice care while staying at a daughter's home in City B. You would code City B for the zip code, since this is where the hospice services are being provided. Now I'm going to turn back to Zinnia to walk us through a practice scenario.
Thanks, Brenda. Zoe, please put the scenario in the chat. In this hypothetical scenario, Mr. M was discharged from the hospital after a lengthy acute care hospital stay. His cancer treatments have been stopped, and he was informed of a prognosis of less than 6 months. He decided to move into his daughter's home and elected to use hospice services. The nurse arrives at the home to conduct the admission. Let's go to the next slide and launch the poll. So what is the correct response for the site of service admission? Okay, I think we can close the poll and launch the results. So if you chose 01, you are correct, since the patient is at a home in a residence, even if it's not his own home. Let's try another one. When completing the HOPE tool, which zip code should the nurse put in the hospice record? Okay, I think we can close this one as well. And the correct answer is B. The patient is staying in the daughter's home while receiving hospice services, so you would record the daughter's zip code. Now we'll turn it back to Brenda to review more items from Section A.
Thanks, Zinnia. So this one is the Social Security and Medicare numbers, and this item is marked revised only because the old version currently in the Hospice Item Set had a reference to the railroad insurance number that's no longer being used. This item is included on each of the item sets since it's also one that's used for record matching. And here are a few coding instructions for the Social Security number. This actually addresses a very common help desk question. While a Social Security number should be submitted whenever available for record matching, if there is no Social Security number or the patient refuses to provide it, this field may be left blank. And here are a few coding instructions for the Medicare number. So this is an identifier assigned to an individual for participation in this national health insurance program. It's also referred to as the Medicare Beneficiary Identifier, or the MBI. To fight theft, identity theft, CMS replaced the SSN-based Health Insurance Claim Number, or HICN, with the MBI several years ago. You should confirm that the name on the record matches the patient's name on the Medicare card. But if the patient has no Medicare number, this field may be left blank. So here are some coding tips to avoid inaccuracies in the patient record matching. The Social Security number should only be left blank if the patient does not have a number or it's unavailable. The Medicare number is not intended to reflect the patient's payer source. It's only used here for patient identification purposes. And a few more coding tips. This has also been a frequent issue that's brought to the hospice quality help desk. If the hospice is notified that the patient does have Medicare and has a number after the record's already been submitted, then you can just include it on the next record when it is submitted. Including a Medicare number on the next record does not require a modification request to the original admission record or require the patient to be discharged and then readmitted, which is very frequently the question we hear from hospices. And here's a screenshot of the Medicaid number. This one is also unchanged and would be included in all hoped for time points. You should enter the Medicaid number if the patient is a Medicaid recipient. Enter one number per box, beginning at the leftmost box. You would enter a plus sign if it's pending, or you would enter N if the patient is not a Medicaid recipient. You want to confirm the patient's legal name on the record matches what's on the Medicaid card, but you can leave the item blank if the patient refuses to supply his or her number or if it's unknown. And a few more coding tips for this Medicaid number. Check the patient's Medicaid card, admission or transfer records, or the hospice clinical record for their Medicaid number. The Medicaid number is not intended to reflect the patient's payer source. It is for patient identification purposes only. If the patient does have Medicaid, you would enter the Medicaid number even if Medicaid is not a primary or secondary payer. As with the Medicare number, if the hospice is notified after the record has been submitted and the patient does have a Medicaid number, you can just include it on the next record. This addition would not require a modification request. Now, A0810 sex is the same familiar item you use now, although the name and the number has changed. This will replace A0800 gender. Please note the patient's sex must match what is in the Social Security system. This is only to assist in the correct identification and provides demographic, sex-specific health trend information. So here's a screenshot of one of the new items, ethnicity, and this is only collected on admission. There are 7 choices here, and you check all that apply. A1010 race is also new. An older version of this in the HIS is combined with ethnicity, A1000 race ethnicity. This was removed for hope, and as with the new ethnicity item, this is only collected on admission. Now let's look at a few coding instructions. So first, you're going to ask the patient to select a category or categories that most closely correspond to the patient's ethnicity and race from each list. And respondents should be offered the option of selecting one or more categories. These are both check all that apply. So if a patient is unable to respond, a response from a caregiver and a responsible party or the medical record might be used. You would code X if the patient is unable to respond. If a response is determined by the caregiver or responsible party or medical record, you would check all the boxes that apply, including that the patient is unable to respond themselves. If no other resources provided the necessary information, you would only code X, patient unable to respond. So for both items, code Y is for when the patient declines to respond. And when that happens, you would only code Y, patient declines to respond. In these situations, you would not code ethnicity or race based on other resources like the family or caregivers. And you want to complete these items as close to the admission as possible. So here are just a few coding tips for these two. Having a standard set of these self-reported items for both ethnicity and race allows for the comparison of data within and across multiple healthcare settings. And it's an important step to improving healthcare quality and health outcomes. Please note that these categories are not used to determine eligibility for participation in any federal program. So here's another one of the new items, and this one is asking about preferred language. It's only asked at admission. For this item, you ask what the patient's preferred language is. Then ask if the patient needs or wants an interpreter to communicate with a doctor or healthcare staff. It's acceptable for the caregiver or responsible party to be the interpreter if the patient is comfortable with it and the caregiver agrees to translate exactly what the patient is saying. Now, if the patient, even with the assistance of an interpreter, is unable to respond, a caregiver or responsible party should be asked. If neither is able to provide a response, then the medical record documentation can be used. This item should be completed as close to the time of admission as possible. And here's a coding tip for language. The preferred language is what the patient primarily speaks or understands. American Sign Language, or ASL, can be reported as the preferred language if the patient needs or wants to communicate in that manner. Let's turn back to Zinnia to look at a scenario to practice some of these new items.
Thanks, Brenda. So, when asked about ethnicity, Mr. M explains he was born in Puerto Rico and identifies as Puerto Rican, even though he has been in the U.S. since he was 6 years old. When he asked about race, he declines to respond, and does not identify race, and changes the subject. Mr. M speaks both Spanish and English, but prefers speaking English and does not feel he needs an interpreter. Let's go to the next slide. So, how would you code ethnicity for this patient? As a reminder, just remember to look at all the response options. So, the answer is C, yes, Puerto Rican. Let's try another one. How would you code race for this same patient? So, you are correct if you chose Y, patient declines to respond. Okay, let's go to the next slide for activity on this scenario. How would you code language for this patient? And note, this is a two-part on the polling. Although Mr. M stated he speaks both Spanish and English, he prefers to speak English. He also did not feel he needed an interpreter, so you would code 0 for no. At this point, I'll turn it back to Brenda.
Thank you, Zinnia. So now let's look at A1400 payer information. This item is currently in use in the HIS. One minor revision made was that the word payer was changed from payor with an O, and this was done to align with the spelling that's used in some of the other post-acute care settings. This item's also been added to the new HUV item sets. This is just in case there's a change in payer that can be captured during those additional visits. So here are a few coding instructions. Check the box or boxes that best correspond to the patient's current existing payment sources. Check all that apply. This item should identify all current existing payer sources that the patient has, regardless of whether the payer is expected or likely to provide reimbursement for any of the services, supplies, or medications, for example. Pending payer sources should not be included here. So you would not report payment sources that have been applied for example, someone that applied for a Medicaid application. Payer sources can be based on the patient or caregiver report, and providers should make every effort to validate these payer sources by asking to see their cards, for example, the Medicare or Medicaid card. So A1805, admitted from, is an existing item collected only on admission. The response options for this item have been slightly revised to align with the same item used in other settings. And just a few coding tips for this item. You'll enter the response that reflects where the patient was at the time of the referral to hospice. The term admitted from does not necessarily mean that the patient left the facility to be admitted to hospice. The location immediately before admission may be the same as immediately after, or the location may be different, such as a patient who elects hospice while they're still in the acute care hospital, but they begin hospice services once they return home. And as I mentioned before, the term SNF is not synonymous with nursing facility. You would only use SNF for patients who are actually receiving skilled nursing facility care in a SNF. If they're in a nursing facility but not receiving skilled nursing, you do not use that option. You would code 02 nursing home for long-term care facility. So A1905 living arrangements is another new item for HOPE in Section A, and it asks about the patient's living arrangements at the time of the admission. The choices include living alone, living with others, or in a congregate home or an inpatient facility. Choice number 5 is for those who do not have a permanent home, or it might mean they have unstable housing, or someone might be experiencing homelessness. And here's a coding tip for this item. If more than one code applies, select the code with the greater numeric value. For example, if a patient lives with their spouse in an assisted living facility, then you would code 3, congregate home. Another new item is A1910, the availability of assistance, and it's asking about the level of in-person assistance the patient has from available and willing caregivers at the time of admission. This assistance is asking specifically about able and willing caregivers, and it does exclude any hospice or facility staff, so would only be collected on admission, even if something was to change throughout the hospice stay. And again, I want to emphasize it does not include facility staff because that would really skew the data for all the patients that actually reside in a facility and have 24-hour care. So the coding instructions, the patient caregiver interview can be used to code this item. In the event that the patient cannot respond and no caregiver is present, you can use any facility staff, the clinical record, or referral information to code this item. And now I'm going to turn it back to Zinnia to review a scenario to practice some of these items.
Thanks, Brenda. So this scenario is focused on the last 2 new items in Section A, which is living arrangements and availability of assistance. So Mr. M is settling into his daughter's home in a room on the first floor. He's still very independent, and his room is close to a bathroom. He can prepare small meals for himself during the day. He explains that his daughter leaves very early for her job at a nearby hospital, but his son-in-law works from home with few exceptions. We know from talking with his daughter that both she and his son-in-law are able and willing to help them. Let's go to the next slide and launch the poll. So based on the scenario, how would you code living arrangements for this patient? So if you answered 2 or coded 2, you are correct. The patient is living in his daughter's home in order to be with family. Thus, the patient lives with others in the home. So, okay, let's go to the next slide and launch another poll. So how would you code availability of assistance for this patient? The correct answer would be code 1, around the clock, 24 hours a day with few exceptions. And it looks like about 69% of our attendees did answer. Those that did answer got it right. So Mr. M will have available assistance from able and willing caregivers most of every day. Keep in mind that you will want to confirm that there are actually willing and able assistants and not just they happen to live in the same home. Okay, I'll turn it back to Brenda.
Okay, thank you, Zinnia. And this happens to be our last item in Section A, and this is A2115, reason for discharge. This item has not changed, and it's collected at the time of discharge. And here's a slide just giving you the definition for discharge for cause. This is a discharge made because the patient or perhaps another person in the patient's home is exhibiting behavior that's disruptive, abusive, or uncooperative to the extent that delivering hospice care to the patient or the ability for the hospice to operate effectively is seriously impaired. And for this item, you review the clinical record, including a discharge plan and discharge order for any documentation of discharge reason. Code the response that corresponds to the patient's reason for discharge. As a reminder, hospice does not need to discharge patients when there is a change in the payer or for other administrative type processes such as missing a face-to-face visit whenever there's no interruption in the care of the hospice services. My colleague and the next presenter, Terry Mata, will now share key takeaways from this last section.
Hey, everybody. Thanks, Brenda. Let me introduce myself. I'm Teresa Mata, an RN with over 30 years of clinical geriatric nursing, administrative, and quality improvement experience in skilled nursing facilities, assisted living, and subacute care. My work is focused mostly on CMS projects in these and other post acute care settings, as well as hospice, opioid and substance use disorders, and many years on CMS contracts related to the development and maintenance of patient assessment instruments, including HOPE. So here are the key takeaways thus far. The HOPE tool will be implemented on October 1st, 2025. Most of the items in Section A, Administrative Information, are familiar to hospices, although some have slightly been altered. Section A contains several new items, including 2 new items that ask about the patient's living conditions and the availability of assistance at the time of admission to the hospice. So now let's go through 2 more sections, Section F, Preferences, and Section I, Active Diagnoses. At the end of these sections, you should be able to explain how to code Section F preference items, describe how some of the new response options for I0010 principal diagnosis and the new section of Section I that documents comorbidities and coexisting conditions are coded. We'll start with Section F preferences. Section F contains 4 data elements that have not changed from what is currently in the HIS. So let's walk through the screenshots for each of these preference items. The first is F2000 CPR preference. This item, as I said, is unchanged, and as with all the items in this section, is only collected on admission. The next one is F2100, other life-sustaining treatment preferences other than CPR. And F2200 is asking about preferences related to hospitalization. And the last one in this section, F3000, asks about spiritual and/or existential concerns. So here are some coding instructions for these items. Completion of these items should be based on what is included in the clinical record and can be extracted from the record. Review the clinical record for any information that documents a discussion of patient preferences for CPR, other life-sustaining treatments, hospitalization, and spiritual and/or existential concerns. For these items, you can consider care processes and discussions that are documented in the clinical record that took place during pre-admission or educational visits, as well as those during the admission assessment window. After reviewing all the documentation in the record, when you discover the date on which the very first discussion occurred, that's the date that you're going to enter in for each of these items. Here are some additional tips to help you code the preference items of CPR, other life-sustaining treatments, and hospitalization. Provided there is evidence of involvement from the patient and/or responsible party, a new order or form completed during pre-admission or after the admission to hospice is sufficient. However, it's important to remember that orders alone, for example, a new DNR order, without evidence that there was a discussion with or involvement from the patient or responsible party, are not sufficient to code yes for CPR preference. For these same 3 items, if there are pre-existing orders, such as physician order for life-sustaining treatment or POST, or other such forms signed in a prior care setting, the hospice should reaffirm the patient's preferences and document them in the clinical record. The bottom line is that you should always confirm that there is evidence of a discussion or attempted discussion within the clinical record. For F2100 other life-sustaining treatment preferences, note that there are no comprehensive list of life-sustaining treatments. And to reiterate for this item, you'll need to ensure that there's documentation in the clinical record that there was a discussion or attempted discussion with the patient and/or responsible party about the patient's preference for any life-sustaining treatment other than CPR, and to code either that as the discussion occurred or attempted, but the patient responsible party refused to discuss. The yellow box on this slide lists a few examples of life-sustaining treatments, such as ventilator support, tube feeding, dialysis, blood transfusions, antibiotics, and intravenous or IV fluids. For F3000, as with sustaining treatments, life-sustaining treatments, there's no comprehensive list of spiritual and existential concerns. So documentation in the clinical record indicating that a member of the hospice staff or IDG discussed or attempted to discuss these concerns is sufficient to code either 1 yes and the discussion occurred, or code 2 yes but the patient or responsible party refused to discuss. Brief statements or data in the clinical record denoting a patient's religious affiliation or offering a spiritual visit are not enough to code yes for F3000A. And a few more coding tips for this item. While these conversations are best held face-to-face, phone conversations with patients and families about spiritual existential issues can be used as long as the clinical documentation supports the discussion occurred. Keep in mind that a discussion with the patient and/or caregivers about spiritual or existential concerns can be initiated by any member of the hospice staff or IDG. Now let's turn it to Zinnia to walk us through a practice scenario.
Thanks, Terry. So we do have quite a few polls coming up, so I hope everyone's ready. During the first visit to the home on October 23rd, 2025, the hospice nurse asked Mrs. T about her preferences for care and treatments. Her prolonged illness and complications from cancer have resulted in numerous hospitalizations. She is firm about her preferences to remain at home if possible during her final months. She presents the nurse with the pulse form that was signed by her physician just 1 week ago. When the nurse asks more about the pulse, Mrs. T explains that she does not want any aggressive treatment, such as CPR or ventilation support, if she was to stop breathing. However, she would like to take antibiotics if she gets an infection and would like IV fluids if she needs them to help with severe bouts of dehydration and nausea. Her physician is aware of her preferences. Okay, so let's go to the poll. This is the next slide. So how would you code CPR preferences for this patient? Most everyone got this one right. The correct response is 1 yes. The discussion occurred. Then you put the date for the discussion. Okay, so we have a couple more questions related to the scenario. So if you need a reference for the scenario, it is in the chat. On the next question, 9, how would you code other life-sustaining treatment preferences? So as with the last item, the correct response is 1 yes, and the discussion occurred. And you would also record the date of that discussion. Okay, for the next question, how would you code hospitalization preferences? This one is also coded 1 yes, and a discussion occurred. And again, record the date of the discussion, of course. And for the next slide, we'll talk about spiritual concerns. Although the nurse asks about spiritual concerns, Mrs. T declines to discuss the subject. She explains that it is something she discusses during her regular visits with her rabbi. So let's open the polling for this one. How would you code spiritual existential concerns for this patient? Looks like a majority did answer yes, but the patient caregiver refused to discuss, and that is the correct answer. Some answered 1 yes, the discussion occurred, but again, they refused to discuss. So number 2 was coding 2 was the right answer. Okay, so we've completed section F. Thank you, Terry, for walking us through those items. And now I turn it back to Brenda, who will walk us through section I.
Thanks, Zinnia. So we have one more section before, and it's a short one, before we take a break. So let's walk through section I, active diagnoses. So section I basically has only one item, and this one's been revised, is much more robust than the one that's in the current hospice item set. And this is only collected at admission, doesn't change even if more diagnoses come along as you have the patient on service for a while. The first part of this is the principal diagnoses. So there are many more options to choose from. This list was created based on results of national testing and the most common diagnoses found for hospice patients. And the list includes neurological conditions, stroke, chronic obstructive pulmonary disease, cardiovascular, excluding heart failure, and then heart failure, liver, and renal disease. And if you don't find the correct diagnosis for your patient on this list, you can always just choose 99, none of the above. So a new addition to this item is part 2, a check all that apply from a list of comorbidities and coexisting conditions. And while this is not a full list, there are many of the common conditions you may see with your hospice patients. And if there is something that's not listed, you can always choose other medical conditions. Now for a few coding instructions. After reviewing all available information for the principal diagnosis, this is the condition that is chiefly responsible for the patient's admission to hospice. The diagnosis that most contributes to the patient's life expectancy of 6 months or less, if the illness were to run its normal course. This item is only collected on admission and should be completed based on the patient's principal diagnosis at the time of the admission to the hospice. So to determine the principal diagnosis, you would review the clinical record information. You don't use external sources from the clinical records. Review all the response choices before you make a selection, or code 99, none of the above, if your patient's principal diagnosis is not listed. And here are some coding tips. So code 1, cancer for all types of cancer. Code 2, dementia. This includes Alzheimer's disease and other types of dementia such as Lewy body. And there's a note on this slide explaining that there are 2 principal diagnosis response codes related to the cardiac conditions. One is for cardiovascular conditions excluding the heart failure, and other is very specific to heart failure. So here is for comorbidities and coexisting conditions. You review the medical record. You're going to check all comorbid or coexisting conditions that are addressed in the plan of care or that might have the potential to impact the plan of care as time goes on. Don't include the principal diagnosis except if the patient has a secondary cancer. Selections for this item are not necessarily related to the principal diagnosis. It can be any comorbidity or coexisting condition. And here's a definition of what we mean by comorbidities. This just refers to diseases or medical conditions that occur simultaneously with the principal diagnosis. I'm going to turn it back to Zinnia to go through another practice scenario.
Thanks, Brenda. So here's a scenario focused on the principal diagnosis. When completing the hospice admission, the nurse confirms the principal diagnosis by reviewing the documents in the patient's medical record. Based on documentation from her oncologist and confirmed with the hospice medical director, the terminal prognosis is determined to be stage 4 ovarian cancer. Let's go to the next slide and launch the poll. How would you code principal diagnosis for this patient? Pretty easy one. Looks like everyone pretty much got it right. The correct response is code 01, cancer. It is clear from the medical records that the terminal diagnosis is ovarian cancer because it most contributes to the patient's life expectancy of 6 months or less. So now let's continue with the scenario on the next slide. The nurse reviews the list of coexisting conditions and comorbidities found within the medical record. She notes that this patient also has a history of the following: squamous cell skin cancer, chemotherapy-induced peripheral neuropathy, and hypoglycemia. Okay, so let's open the poll on the next slide. And how would you code the comorbidities and coexisting conditions? So the correct responses for this one would be to code cancer, neuropathy, and other medical conditions. So although typically one would not include the comorbidity if it is also the principal diagnosis, the one exception is when there's a secondary cancer. So I'll say that again. The exception is when there is a secondary cancer. And this was a check all that applied. So at this time, I'd like to invite my colleague, Teresa Rada, to introduce herself and then provide us the key takeaways, section F and I.
Thank you, Zinnia. My name is Teresa Rada. I am a senior associate at Apt Global. I am also a physical therapist with many years of clinical and administrative experience, including inpatient, outpatient, and home health and hospice. Since joining Apt in 2019, I have contributed to many federal healthcare initiatives across acute and post-acute care settings. It's been a privilege to be part of Hope development since the inception, and I'm excited about implementation. So let's review the key takeaways from section F and I. Section F preference items are collected based on the first discussion that occurred, including those that took place during pre-admission or educational visits. Item I0010, Principal Diagnosis, has been expanded to include more options and comorbidities and coexisting conditions. For comorbidities and coexisting conditions, you do not need to include the principal diagnosis, except if the patient has a secondary cancer. Thank you for your attention. It is now almost 2 o'clock. We're going to take a 20-minute break. Please make sure you come back on time because we will discuss critical new hope items in Section J, health conditions, and Section M, skin conditions, which is a new section for hope. And you don't want to miss it. So we'll see you back here in 20 minutes. Welcome back. Let's get started. I'm going to guide you through the coding for Section J, health conditions. Here are the objectives for this section. You should be able to identify the new data elements in Section J, discuss the coding of J0915, neuropathic pain, explain the coding of the symptom impact and symptom follow-up items in Section J, and identify who can complete J2052, symptom follow-up. This slide outlines the items in Section J. There are 6 new items listed in the first column. The middle column lists the 4 items carried over from the HIS and remain unchanged. And finally, there is 1 item that was revised slightly. As with the other sections, I will review the coding for the items, and then Zinnia will present a scenario so you can have a chance to practice coding. This is the first item, J0050, death is imminent. This is a new item collected at admission, HUV1, and HUV2. It asks the clinician, at the time of this assessment, and based on your clinical assessment, does the patient appear to have a life expectancy of 3 days or less? The clinician should respond with code 0, no, or code 1, yes. The clinician would choose code 1, yes, if their clinical assessment and judgment determine the patient is expected to live 3 days or less. Please note that the response to this item does not indicate a statement of the actual prognosis, but rather the likelihood that death may be imminent based on the symptoms and the clinician is observing. And remember, when counting the number of days, the assessment visit is day 0. Now I will turn it back to Zinnia to walk us through a scenario and apply this guidance.
Thanks, Teresa. So with these new items you're discussing, I'm really looking forward to the polling results after each scenario. These might be a little bit tougher. There are about little over 700 attendees, and about 400 are actually responding from to the polls at the last section. I really hope more people will participate in polling. So what I'll do is I'll give a bit more time, especially during these next sections, and I'll announce when I will plan to close the poll. Probably give you about 5 or maybe 10 seconds. Okay, so let's look at the scenario. So during the Hope admission visit, the nurse assessing Mrs. P observes no response to verbal stimuli, accumulating secretions with an inability to clear or swallow them. Upper and lower extremities are mottled, cyanotic, and cool to the touch. The family reports she is not waking or trying to open her eyes when they talk to her. The family also reports Mrs. P has not urinated in more than 24 hours and does not respond when they ask if she needs to urinate. Let's go to the next slide and launch this poll. So how would you code imminent death? At the time of Mrs. P's assessment on the clinical nursing assessment, Does Mrs. P appear to have a life expectancy of 3 days or later? So, yep, the correct answer is 1. Yes, 98% of those that did respond got this right. Mrs. P was exhibiting clinical signs and symptoms of imminent death. All right, and I'll turn it back to Teresa.
Thanks, Zinnia. The first item is J0900 pain screening. This item was carried over from the HIS and is still collected on admission. J0900 pain screening has 4 parts. The first question asks if the patient was screened for pain. This is a yes/no question. This is followed by the date of the first pain screening. Part C asks about pain severity, and the last part asks about the type of pain tool used. To code J0900 pain screening, the clinician should assess the patient for the presence of pain. The clinician should review the clinical record for information regarding pain screening and also consider if a standardized pain screening tool was used. Then the clinician chooses yes or no based on the assessment or clinical record review. And then for Part B, the clinician enters the date for the first pain screening. Keep in mind, it is possible that multiple pain screenings will be documented in the clinical record. The clinician should identify and use the first one. As a reminder, items carried over from the HIS can still be completed by data abstraction. J0900 pain screening is an example of this. Here are some coding tips for Part C and D. For Part C, choose the severity at the time of the first pain screening. If there is a range, use the highest level of severity. Then for Part D, choose the tool used to rate the severity. If a non-numeric scale was used, use the standard established for that scale. The second pain item is J0905, pain active problem. This is not a new item for hospices and is collected on admission. This data element asks, is pain an active problem for the patient? Here are some coding tips to assist with coding J0905. If the clinician determines pain is an active problem for the patient, they will code 1 yes, even if the pain is not present during the clinical encounter. The clinician can use patient-specific findings and/or conversations with family or caregivers to determine whether pain is an active problem. Clinicians might need to consider historical reports of pain, reports of recent symptoms, and current treatment, both pharmacologic and non-pharmacologic. Here are some additional coding tips. If there is a clinical documentation that the patient is currently taking pain medication, this is evidence that pain is an active problem. Clinicians should determine whether pain is an active problem based on their responses to the pain screening. Any indication that pain is mild, moderate, or severe would suggest that pain is an active problem for the patient. Code 1 yes if there is documentation in the clinical record that indicates pain is an active problem. Otherwise, code 0 no. The next pain item is J0910, comprehensive pain assessment. Just like the prior pain items, this one is also not new and is collected on admission. This item has 3 parts. The first asks if a comprehensive pain assessment was performed. Part B asks for the date of the comprehensive pain assessment, and Part C asks the clinician about the elements included in their comprehensive pain assessment: location, severity, character, duration, frequency, factors relieving or worsening pain, and effect on quality of life, and finally, none of the above. Let's review some coding tips, and just a reminder that a comprehensive pain assessment should address multiple aspects of pain, including signs and symptoms for nonverbal patients. The clinician can use a caregiver report and clinical notes. Also, for any of the 7 characteristics, select options based on whether there was an attempt to gather the information from the patient or caregiver. The last item in the pain series is new for Hope. It's J0915, neuropathic pain. It is also collected at admission. This item asks if the patient complains of pain or describes their pain with characteristics of neuropathic pain, like burning, tingling, pins and needles, or hypersensitivity. Here is the definition of neuropathic pain. Neuropathic pain is caused by a lesion or disease of the somatosensory nervous system. Let's review the coding tips for neuropathic pain. The clinician should use the patient and caregiver interview, observations, clinical assessment, and clinical judgment at the time of the assessment visit to determine the presence or absence of neuropathic pain and choose yes or no accordingly. Now I will turn it back to Zinnia to help us practice coding the pain items.
Thanks, Teresa. There was a lot of great coding tips for those new items. There are a few polls this time around, so hoping we can increase the response rate. So get ready. The hospice nurse conducts the admission assessment of Mr. K on November 5th, 2025. The nurse observes Mr. K during conversations with him and his family. Outwardly, he does appear comfortable with nonverbal signs of pain. However, when he stands so the nurse can examine him closely, the patient grimaces and moans. He relaxes once he's in a resting position. The nurse asks Mr. K about his pain. He responds by saying, "It's not too bad. I take Tylenol every once in a while." Based on the observation and discussion with Mr. K, the nurse determines he has mild pain. But we'll use this part of the scenario to code pain screening and pain active problem for the next couple questions. Let's go to the next slide and launch the poll. So how would you code pain screening? Was the patient screened for pain? If so, you'd enter the date and then enter the pain severity. For the polling that you're seeing on your screen, you may need to scroll down a little bit so that you can see number 4, the fourth part. I see people are responding to that. The answer there, the nurse screened Mr. K for pain at the time of the visit on November 5th, 2025. The nurse noticed Mr. K grimaced and groaned when he stood, and Mr. K told her he takes Tylenol intermittently. Okay. And it looks like for the first response, the correct answer, yes. 99% of people did get that right and provided a date. And then for the third section with a pain severity, looks like 93% of folks did get that right. And then for the standardized pain tool, it's a little bit different because let's see, we have 47% had a verbal descriptor because of the interview. All right, we can close that. Let's go to the next one. So how would you code pain active problem? In this scenario, pain is an active problem for Mr. K since the nurse determined the pain was mild and also observed signs of discomfort. So I'll build on Mr. K's scenario on the next slide. So Mr. K tells the nurse he developed burning, tingling pain in his feet during his cancer treatments. He says the pain makes standing and walking more difficult. The family tells the nurse they hesitate to take him out on outings since they fear hurting him. Okay, so let's launch the next polling question. How would you code comprehensive pain assessment? Remember to check all of the characteristics that apply. Okay, so since pain is an active problem for Mr. K, it is clinically appropriate for the nurse to complete the comprehensive pain assessment. So this is coded 1 yes, with the date of November 5th, 2025. So through the assessment, the nurse identified his feet as a location of pain, and she determined the pain is mild in severity. Mr. K reported his pain is burning and tingling, and standing worsens the pain. The family is hesitant to take him on outings, which impacts his quality of life. So therefore, 1, 2, 3, 6, and 7 are checked. Okay, let's launch the next poll. How would you code neuropathic pain? This one probably was an easy one, right? Mr. K reported burning, tingling, pain in both feet during his prior cancer treatment. So based on that discussion, for Mr. K, the nurse did code 1 yes, and 96% did get that right. It's a great job. All right, Teresa, I'll turn it back to you for the next set of items.
Okay. Now we will look at the shortness of breath items. There are two. The first is J2030, screening for shortness of breath. This item was carried over unchanged from the HIS and is collected on admission. This item has 3 parts. Like the pain items, the shortness of breath items are commonly completed by data abstraction from the clinical record. Let's examine the coding instructions. The clinician should assess the patient for the presence of shortness of breath. Choose yes or no based on the clinical record or the assessment visit. Then enter the date of the first screening for shortness of breath documented in the clinical record. Part C asks if the screening indicates the presence of shortness of breath in the patient. If a review of the documentation indicates the presence of shortness of breath, but there is no indication of severity, the clinician would choose code 0, no. Here are some additional coding tips for J2030, screening for shortness of breath. Clinicians should determine whether shortness of breath is an active problem at the time of the screening. Consider patient-caregiver report of trouble breathing at rest or with exertion or other clinical signs of shortness of breath. Think about whether shortness of breath is an active problem even if it does not occur during the assessment visit. There are also situations where there is an order for PRN oxygen, but shortness of breath is not an active problem at the time of the screening. Now we will look at J2040, treatment for shortness of breath. This item was carried over from the HIS, but Part C, types of treatment, was removed. This item is still collected only on admission. Part A asks if any treatment was initiated. You would code 0, no, if a treatment was not initiated or offered, or there is no documentation that a treatment for shortness of breath was initiated or offered. If a patient declined a treatment that was offered, you would code 1, no, patient declined treatment. And you would code 2, yes, if treatment for shortness of breath was initiated and or there is documentation that a treatment was initiated. And like many of the other HOPE items, Part B asks for the date that the treatment was initiated. Here are some coding instructions for non-medication interventions for shortness of breath. Some examples are fans or positioning or patient education. Use the date when the first non-medication intervention was discussed. For pharmacologic interventions, treatment is considered initiated when an order is received and the patient or caregiver has been instructed to begin using the medication. Enter the date of the order irrespective of when the first dose was given. Here are some coding tips for J2040, treatment for shortness of breath. When reviewing the clinical record for treatments, consider both non-pharmacologic as well as pharmacologic measures. Include both scheduled and PRN interventions. Sometimes interventions can have multiple purposes. Only include those for the expressed purpose of treating shortness of breath. Now I will ask Zinnia to walk us through a practice coding scenario.
Thanks, Teresa. So the hospice nurse arrives to conduct the admission on December 5th, 2025. The nurse finds Mr. W anxious with a short, shallow breathing pattern with a rate of 30. The clinical record shows an order for 10 milligrams of morphine by mouth every 4 hours as needed for shortness of breath. The nurse administers a dose of morphine and instructs Mr. W and his family in the dosage schedule. So the nurse also advises Mr. W to use a fan to keep the air moving. So let's launch the poll. How would you code screening for shortness of breath? Was the patient screened for shortness of breath? If so, what was the date of that first screening? And did the screening indicate the patient had shortness of breath? Okay, so during the admission assessment on December 5th, the nurse observed Mr. W to be anxious and short of breath. Okay, for the next polling question, which is also based on the same scenario. So, based on that scenario, was treatment for shortness of breath initiated? Remember, if yes, indicate the date treatment was initiated, and then you can see the options and select the correct answer. So, a fan and morphine interventions were initiated for Mr. W on December 5th. All right, Teresa, back to you for the new symptom impact and follow up visit items.
Okay, here is another new item for Section J, J2050, Symptom Impact Screening, and it is collected at admission, HUV1, and HUV2. It has two parts. Part A, was a symptom impact screening completed? If so, you choose code 0, no, or code 1, yes, if the patient was screened for the impact of symptoms. For Part B, just enter the date that the symptom impact screening was performed. Let's look at the definition for symptom impact. It is defined as the effect of symptoms on the patient. Symptoms may impact a patient in multiple ways, such as sleep, concentration, or day-to-day activities. This is different than the pain severity you marked for the initial pain screening. J2051, symptom impact, is also a new item. It is collected on admission, HUV1, and HUV2. This data element asks the clinician to rate the impact of 8 symptoms on the patient over the past 2 days. They are pain, shortness of breath, anxiety, nausea, vomiting, diarrhea, constipation, and agitation. Here are the coding instructions for J2051 symptom impact. The clinician can use patient caregiver interview, observation, clinical assessment, and clinical judgment to determine and choose the codes that best describe the effect of each symptom on the patient. Here are some tips to keep in mind. The clinician should code item J2051 after considering all the information gathered from the assessment, as well as discussions with the patient, family, and caregivers, as well as their clinical assessment. And remember that this is an assessment of impact, not severity, frequency, or intensity. The next new item is J2052, Symptom Follow-Up Visit, or SFV. It is collected within 2 days after an admission, HUV1, and HUV2 visit, and only if a symptom impact in J2051 is identified as moderate or severe. If a moderate or severe symptom impact is identified on admission, HUV1 or HUV2, in item J2051, the RN or LPN/LVN should return within 2 calendar days to follow up on the moderate or severe symptom identified. If no moderate or severe impact is identified in J2051, there is no need for the symptom follow-up visit to collect J2052. J2052 SFV asks if an in-person visit was completed, and if so, to enter the date. In the event the SFV was not completed, Part C asks for the reason. There are 4 possible coding responses. Code 1, if the patient declined the in-person visit. Code 2, was the patient unavailable at the time of the visit was scheduled or planned? perhaps they were in the emergency department or the hospital or temporarily traveled outside of the hospice service area that day, or maybe they expired. Code 3, were the attempts to contact the patient or caregiver unsuccessful? And Code 9 is used if none of the reasons listed above apply. This is an important tip. In the event a new symptom is identified during the SFV, another SFV is not required for the purpose of HOPE data collection. However, the clinician should follow the standard of care to treat and follow up on newly identified symptoms. The last item for Section J is J2053, SFV symptom impact. This item is collected on admission, HUV1 and HUV2 if a moderate or severe symptom impact was identified in item J2051. It asks the clinician to assess the impact of the symptoms since the last symptom impact assessment. The same coding options found in J2051 are used for this item. Code 0, not at all, if the patient is not affected or well controlled with a current treatment. Code 1 for slight, Code 2 for moderate, Code 3 for severe, or Code 9 not applicable if the patient is not experiencing the symptom at all. A few coding tips to keep in mind. Just like J2051, symptom impact, this item is coded based on the clinician's judgment after considering all the information provided by the patient, family, or caregiver and/or facility staff in addition to their own assessment. Symptoms may impact multiple patient activities, including but not limited to sleep, concentration, day-to-day activities, or ability to interact with others. Now I will have Zinnia walk us through coding the symptom impact items with a scenario.
Thanks, Teresa. That last section was really jam-packed with lots of information. We're going to do the practice scenarios, and there are a few polling questions, so just want to give you a heads up. We are returning to Mr. W, who we met during our discussion of the shortness of breath items. So during admission on December 5th, the nurse found Mr. W anxious and short of breath. She initiated morphine and the use of a fan. So Mr. W also takes the following medications: Ativan at night to manage agitation, Zofran to control intermittent nausea. He reports his agitation and nausea are well managed with no recent episodes. No additional symptoms were identified. So based on the assessment and conversations with Mr. W and his family, the nurse determined that anxiety and shortness of breath had a moderate impact. The nurse told the family she or another nurse would return the next day. As you prepare to code the symptom impact items, I want to remind you of the coding of symptom impact. 0 is used for symptoms that are present but well managed and causing no impact. Code 9, not applicable, is used for symptoms the patient does not experience at all. Okay, so I think we can launch the poll. So how would you code the new symptom impact screening items? So was the symptom impact screen performed? If the screening was performed, what was the date? Everybody got this one right. Mr. W was screened for impact of symptoms during admission on December 5th. Okay, so let's dive a little bit deeper. How would you code symptom impact here? Based on the scenario, rate each of the symptoms listed. Remember, code 0, not at all, 1 for slight, 2 for moderate, 3 for severe, 9, not applicable if the patient is not experiencing the symptom. And the symptoms to consider are pain, shortness of breath, anxiety, nausea, vomiting, diarrhea, constipation, agitation. Again, you may have to scroll down to complete the poll. So during the admission assessment on December 5th, The nurse observed that shortness of breath anxiety had a moderate impact on Mr. W. So anxiety and shortness of breath would be coded 2, moderate. Mr. W does have an issue with nausea and agitation, but he is well controlled with his current medications. Therefore, there's no impact for nausea and agitation, so they would be coded 0. As for the remaining symptoms of pain, vomiting, diarrhea, and constipation, Mr. W is not experiencing any of those symptoms and is not receiving medication for any of the symptoms. So they would be coded 9, not applicable. Okay, let's go to the next slide and we'll continue with the scenario. The LPN returned on December 6th to conduct the symptom follow-up visit. Mr. W was playing cards with his grandson and reported that the fan and morphine were a big help. He told the nurse he can complete his daily activities with minimal shortness of breath and anxiety. The nausea and agitation continued to be well controlled. No other new symptoms were identified. The nurse determines shortness of breath and anxiety have a slight impact and instructs Mr. W to continue the same interventions. So how would you code a symptom follow-up visit item for this scenario? So was an in-person SFV completed? If so, then what was the date? If it wasn't completed, what was the reason? Okay, so the nurse returned the next day, which was December 6th, to follow up on the shortness of breath and anxiety. And then following the skip pattern, the nurse skips part C and moves to the SFV. So there is a skip pattern there. Okay, let's look at the next slide and question. How would you code a symptom follow-up visit or symptom impact? So just like in symptom impact, you rate the impact of every symptom listed. So I'll give you some time here. Okay, so although improved, the anxiety and shortness of breath still have a slight impact on Mr. W. Since the nausea and agitation were well controlled with medication or current treatments. These would be coded 0, not at all. All other symptoms would be coded 9, not applicable. So since the patient is not experiencing any of these symptoms. So there's a lot in this section J, and I know folks will want to review the section a bit more closely after the workshop and just continue to practice to be successful. Okay, at this point, I'm going to turn it back to Terry, and she'll give us a few key takeaways on section J.
Thanks, Zinnia. So I'm going to review some of the key takeaways from this section. The first one is that the response to item J0500, death is imminent, is based on clinical judgment and is not intended as a statement of prognosis. Item J0915, neuropathic pain, is intended to capture a specific type of pain, and the SFV is a new requirement for an in-person visit and is expected to occur within 2 calendar days if triggered by a moderate or severe symptom impact on the HOPE admission, HUV1, or HUV2. Now we'll proceed to the last 3 sections, Section M, Section N, and Section Z. Most of these sections should be very familiar to this audience, maybe with the exception of Section M, which is new. So let's continue on to Section M, skin conditions, Section N, medications, and Section Z, record administration. By the end of this portion of the training, you will be able to identify the new data elements in Sections M and Z, describe the new time points associated with Section N data collection, and be able to summarize the intent and coding instructions for the new items. So Section M, skin conditions. The items in this section document the presence, type, and current treatment of various skin conditions common in the hospice patient population. It's important to recognize and evaluate each patient for current or potential skin injury. This section is a new section containing 3 different data elements that hospices may collect. The 3 data elements are M1190, skin conditions, M1195, types of skin conditions, and M1200, skin and ulcer injury treatments. It's important to assess the patient's skin because skin conditions, wounds, and lesions can affect the patient's quality of life as they could limit activity and be painful. This information helps to identify patients at risk for further complications or skin injury. This first item in the series of new data elements is a skip pattern, and this allows the assessor to move to the next section if the items in this section do not apply to the patient. This data element will be collected on admission and hope update visits 1 and 2. To determine if the patient has any skin conditions, consult the medical record. This information can be found in transfer records, nursing notes, physician notes and orders, and skin assessments. You can also ask the patient and/or caregiver if there are any skin conditions present, then assess those skin conditions. If the patient doesn't have any skin conditions, the response in M1190 should be coded as no. Then the assessor should skip to section N's first item, N0500, scheduled opioid. However, if the patient does have a skin condition, the response in M1190 should be coded as yes, and the assessor should move on to item M1195, type of skin conditions. And so this is a snapshot of this item, and this indicates the patient's types of skin conditions, and the intent of this item is to document those types of skin conditions that the patient has. For this item, you'll review the medical record for any ulcers, wounds, or other skin conditions identified, and then you'll check all that apply at the time of the assessment. So let's look at some of the types of skin conditions discussed in this item. Diabetic foot ulcers. These are caused by neuropathic and small blood vessel complications of diabetes. These complications affect the lower extremities and place a person at high risk for foot injury. They also contribute to a decreased awareness of pain in the feet, along with cracked and dry skin. Other types of skin conditions listed here are open lesions, skin tears, and surgical wounds. Open lesions are lesions that develop as part of a disease, like boils, cysts, and vesicles. Skin tears, which are a result of shearing, friction, or trauma, cause a separation in the skin layers. Full or partial thickness skin tears are coded in this item. Surgical wounds. These are associated with surgical sites, but don't include healed surgical sites and healed stomas or lacerations that required suturing or butterfly closures. Peripherally inserted central catheter, central, and peripheral IV sites are also not coded in this item. The last type of skin condition I'll speak to is moisture-associated skin damage, or MASD. This is defined as superficial skin damage caused by sustained exposure to moisture, such as incontinence, wound exudate, or perspiration, which is why you may have heard MASD referred to as other things such as maceration, incontinence-associated dermatitis, peri-wound, measure-associated dermatitis, and others. The next item is M1200, and it indicates all the skin and ulcer injury interventions or treatments required and in place at the time of the assessment, which can be on admission, HUV1, and/or HUV2. To complete this item, review the medical record, including treatment records and healthcare provider orders for documented skin treatments. Ask the patient, caregiver, and responsible party about any wound treatments. For patients living in a facility, speak with direct care staff and the treatment nurse to confirm conclusions from the medical record review. Some skin treatments can be determined by observation. For example, observation of the patient's wheelchair and bed could reveal if a patient is using a pressure-reducing device for their bed or their wheelchair. For this item, you can check all of the treatments that apply at the time of the assessment, including those that have been initiated or continued. Treatment is considered as initiated if the hospice has received the order and there's documentation that the patient caregiver was instructed to begin the use of the medication or treatment. Here are some coding tips to consider about some of the skin and ulcer injury treatments when deciding which one to code. Pressure-reducing devices. These devices redistribute pressure so that there is some relief on or near the area of ulcer or injury. Turning and repositioning includes a consistent program for changing the patient's position and realigning the body. Dietary measures would include nutrition received by the patient to prevent or treat specific skin conditions. Pressure ulcer care includes any intervention for treating pressure ulcers, such as topical dressings, enzymatic debridement, wound irrigation, and negative pressure wound therapy. Continuing on with these coding tips for surgical wound care, this may include any intervention for treating or protecting any type of surgical wound. For example, topical cleansing, wound irrigation, application of antimicrobial ointments, application of dressings of any type. And then non-surgical dressings. These may include, but aren't limited to, dry gauze dressings, dressings moistened with saline or other solutions, transparent dressings, hydrogel dressings, and compression bandages. You would not include adhesive bandages like Band-Aid bandages or wound closure strips in this item. And dressings do not have to be applied daily in order for them to be coded here. And finally, application of ointments and medications. These may include things such as topical creams, powders, and liquid sealants used to treat or prevent skin conditions. This category does not include ointments used to treat non-skin conditions like nitropase for chest pain. Now that we've gone over these new items, Zinnia, can you please take us through some practice scenarios?
Thanks, Terry. There are about 7 polling questions. I just want to remind everyone that the answer on the slide is correct. I think we were having a little technical issue with the polling, so just note that. Okay, for this scenario, Ms. L was admitted to hospice with a diagnosis of end-stage lung cancer. During the initial nursing assessment, the nurse asked her and her caregiver about any skin conditions she may have. She explained that she had a skin tear on her left elbow and a small ulcer on the outside of her right ankle. Let's go to the next slide and launch that poll. So based on the scenario, does Ms. L have one or more skin conditions? I think I'll only give you about 10 seconds to answer this one. Okay, I think we can close this poll. Everybody got this one right. The correct response is 1, yes, because she said she had a skin tear and a small ulcer on her ankle. Okay, let's just build on the scenario. Upon initial examination, the nurse noted the skin tear on Ms. L's left medial elbow and stage 2 pressure ulcer on her right lateral malleolus, and stage 1 pressure injury as evidenced by non-blanchable skin redness on her coccyx. She did not have any other wounds, lesions, or skin conditions present. So based on the assessment conducted, which skin condition should be checked in the type of skin conditions? Let's launch that poll. So the correct response is to check C and E because she has a skin tear on her left elbow, a stage 2 pressure ulcer on her left lateral malleolus, and a stage 1 pressure injury on her coccyx. Okay, so let's continue. And we have more on the scenario. The nurse consulted the patient's medical records and noted dressing orders. She removed the current dressing and cleaned both affected areas. She applied a transparent film dressing to the skin tear and applied a bordered gauze dressing with hydrogel to the stage 2 ulcer on her right lateral malleolus. Let's go to the next slide. Related to the stage 1 pressure injury, the nurse noted that Ms. L has pressure reducing devices on her bed and chair. She asked how often does Ms. L reposition herself? And she said, not very often, maybe every couple hours when I need to go to the bathroom. The nurse recommended a schedule of more frequent turning and repositioning, like every 1 to 1.5 hours, as Ms. L or her caregiver can tolerate. So let's launch the poll. Now, based on what you just heard, which interventions or treatments should be checked in skin and ulcer injury treatments? And let's look at the answer. So what you should have checked is A and B for pressure reducing devices for the chair and the bed. C was turning and repositioning program. The E for the pressure ulcer care, and G, the application of non-surgical dressing with topical medications. Okay, so we'll go to the next slide with the scenario, but I'm not going to have you poll for a little bit, just maybe for 1 or so, give you a little break. We're now going to switch to this different patient. Mr. A was admitted to hospice with late-stage congestive heart failure and cardiomyopathy. Upon admission, the hospice nurse found the patient to have no skin conditions. So, how would you answer skin conditions for Mr. A? Well, on the next slide, on admission, Mr. A does not have any skin conditions noted. Therefore, skin conditions should be coded 0, no. Because there were no skin conditions noted, the nurse will skip over to the next 2 skin items to section N. Okay, so let's continue with the scenario. And after this one, I will ask for polling for those next few questions. The nurse returned to Mr. A's home on day 8 to conduct the Hope Update Visit, or HUV1. The nurse asked him about any skin conditions. He stated he had noticed a sore on his left leg. Upon assessment, the nurse identifies a venous stasis ulcer on his left leg. Let's look at the next slide and launch that poll. So based on the HUV1 assessment, does Mr. A have one or more skin conditions? This is just a yes/no response. Thanks for closing the poll. The correct response is 1, yes, because during the HUV1, the nurse identified he had a venous stasis ulcer on his left leg. Okay, so now let's continue to code type of skin conditions, and we'll open that poll. Okay, as you can see in this poll, we could not include all the options, but more importantly, the right answer options are there. So take a moment to take a look at those based on that scenario. So which skin types or skin conditions should be checked? What skin type or conditions? Okay, so let's close that and we can launch that and look at the answer. You should have checked G, ulcers other than diabetic or pressure ulcers, because he has a venous stasis ulcer on his left leg. Okay, so we'll continue with the scenario. We'll build on that a little bit. The nurse consulted with the hospice medical director, and an order was received to begin a 3-layer compression bandaging protocol, which after the first application is to be reapplied every 5 days. So for the next poll, based on what you just heard, which interventions and or treatments are in place for Mr. A's skin conditions as of the HUV1 assessment? So note that you'll see on the slide does not match the poll. Again, the poll did eliminate some few wrong options, but the correct answer is on that poll. So the correct answer is G, application of non-surgical dressing with or without topical medications other than feet. So this is because the patient had a treatment ordered by the hospice medical director for his venous ulcer, which included the application of a compression bandage to be reapplied every 5 days. All right, so great job for completing section M. Now I'll turn it back to Teresa to discuss section N, medications.
Thank you, Zinnia. I'll now review section N, medications. The items in this section have not changed and were carried over from the HIS. Historically, they have been collected on admission. With Hope, they will also be collected at HUV1 and HUV2. It is important to remember that opioids are commonly used in the management of pain and other symptoms. Constipation is one of the most common opioid-related adverse side effects. Most patients develop some degree of constipation after opioid initiation or dose increases. Reducing opioid-induced constipation has the potential to reduce patient discomfort and improve quality of life. Patients do not develop a tolerance to opioid-induced constipation. Clinical guidelines recommend prophylactic bowel regimens. Here is a screenshot of the first item in section N, N0500, scheduled opioid. First, you'll answer yes or no as to whether a scheduled opioid was initiated or continued. And if the answer is yes, you'll enter the date that the opioid was initiated or continued, irrespective of when the first dose was given. If the nurse initiates an opioid or determines that at the HUV visit that an opioid was continued while conducting the HUV, they would record the date of the HUV. Note that the data submitted for the scheduled opioid item contributes to the Comprehensive Assessment at Admission Quality Measure CBE number 3235. When a scheduled opioid is initiated or continued, a bowel regimen should be initiated. This is part of the QM. Here is the snapshot of N0510 PRN opioid. As you can see, it is similar to N0500 scheduled opioid, and the coding instructions are the same. The PRN opioid item is not part of the quality measure. Here is a coding tip that applies to both N0500 and N0510. You would code 1 yes if the clinical record indicates that a regularly scheduled or PRN opioid was initiated for any reason, regardless of patient symptoms. For the purposes of completing these items, an opioid includes Schedule 2 and Schedule 4 opioids, including hydrocodone and tramadol, because of their side effects profiles, which include constipation. Here is the last data element in section N, N0520, bowel regimen. Again, this item has not changed. It will now be collected at additional time points, HUV1 and HUV2. You would code 0 no if a bowel regimen was neither initiated nor continued, and then skip to section Z. Or you would code 1 no, there is documentation of why a bowel regimen was not initiated or continued, or then complete B for the date a bowel regimen was initiated or continued. If the nurse initiates or determines at an HUV that the bowel regimen was continued, they would put the date that it was confirmed, the date of the HUV was conducted. Here is a coding tip for N0520 bowel regimen. The overarching guidance for N0520B has not changed from HIS to HOPE. When these items were brought over to HOPE, some revisions were made to streamline the guidance or improve clarity. Treatment is considered initiated when the hospice has received the order and there is documentation that the patient or caregiver was instructed to begin use of the medication or treatment. Please note, proactive education on medication and a comfort kit in anticipation of symptoms is not considered initiation until the patient or caregiver has been instructed to begin using the medication. Here are some clinical contraindications that would need to be documented sufficiently to code 1, why a bowel regimen was not initiated. Note that this is not an all-inclusive list, but possibilities include that the patient may have a bowel obstruction or an ileus, diarrhea, no bowel function, a colostomy or ileostomy. Perhaps they are having nausea and vomiting, or recent abdominal surgery, or maybe NPO and taking nothing by mouth. And although this list is not all-inclusive, here are some interventions that might be seen in the clinical documentation to code 2 for a bowel regimen: laxatives or stool softeners, high-fiber supplements, enemas, suppositories, or dietary interventions such as prune juice or a high-fiber diet. Here's the latest coding tip for N0520. This is about any clinical contraindications to a bowel regimen. Basically, what this says is that in order to complete N0520, you may need to review other portions of the clinical record, such as gastrointestinal assessments, elimination status, and bowel function, to find either the bowel regimen or clinical contraindications to initiating a bowel regimen. Now let's try some practice scenarios. Back to you, Zinnia.
Thanks, Teresa. And thanks to Zoe throughout this. She's been putting the scenarios in the chat if you have not noticed that. Okay, so for these next few, I will not launch the poll. These are ones you're probably familiar with. So Miss J was admitted to hospice on October 23rd, 2025, with a terminal diagnosis of breast cancer with metastasis to the lungs. Upon initial assessment, it was noted that she had orders for acetaminophen, which helps her when she experiences pain in her chest, currently rated as 4 out of 10. She doesn't have issues with bowel movements. Due to this information, in addition to the lack of opioid medication orders, the nurse determines a bowel regimen is not needed. So how would you code schedule opioid and PRN? On the next slide, for both scheduled opioid and PRN, you would code 0. No, this is because on the initial assessment, she is not on any opioids. And in this case, the nurse will skip the bowel regimen. Okay, now let's look at the bowel regimen. How would that be coded? So on the next slide, the correct response for that item is also no, 0, because she did not have a bowel regimen initiated or continue, and no date is needed for part B of this question. Okay, now let's build on that scenario. And then after reviewing the scenario, I will open it up for polling. During HUV1, Mrs. J stated that she had been taking her acetaminophen, but was recently been coughing a lot more. And the acetaminophen does not seem to alleviate the chest pressure and increased pain she experiences after coughing. Mrs. J states that it's worse. Her pain is about 7 or 8 out of 10. The nurse contacted the hospice medical director to obtain orders for pain medication and to initiate bowel regimen. An order dated November 1st, 2025 was received for the following: a long and short acting oxycodone. One is scheduled and the other is PRN and Senicide tablets twice per day. The next slide, and we'll launch the poll. Again, if you need to take a look at the scenario I just went through, it's in the chat. So based on that HUB1 assessment, how would you code scheduled opioid? As you can see on the slide, there's 2 parts, an A and a B, and also in PRN, there's 2 parts, A and a B. For scheduled opioid, the correct response for A is 1, yes, because a hospice medical director ordered oxycodone, and that date would be November 1st, 2025 in B. And then the PRN opioid part A should also be coded as 1, yes, because oxycodone was also ordered for breakthrough pain. And then part B should be coded November 1st, 2025, since that date was initiated. So let's try another question on the next slide. Again, in the chat, you'll see the scenario as a reminder. How would you code bowel regimen A and B based on HUV1 assessment? And the correct answer is A, is 2, yes. A lot of people got this right because the bowel regimen was initiated, and the date it was initiated is November 1st, 2025, when the order was received. And that's the date that should be entered in B. So now that we've completed section N, Brenda, are you ready to help wrap us up on section D?
Thanks, Zinnia. So we've reached the last section in course 2, which is section Z, record administration. And I'll pretty much zip through this. Hopefully we'll have some time for some Q&A at the end. It's the responsibility of the hospice to ensure that the HOPE data submitted to CMS are accurate and complete. So this section contains signatures of individuals that completed HOPE, and it verifies accuracy, and the signature of individuals verifying the HOPE record completion. So section Z items, there's one new item added to section Z, and that is ZO350, which is only used for the HUV time points. 2 of the items in this section are not new to hospices, and that is ZO400 and ZO500. So here's the new item, section Z0350. Date assessment was completed. As I mentioned, this is only for the HUV and HUV 1 and 2 time points. For HUV 1 and 2, you'll enter the date that the information was gathered and documented by the assessing clinician, including any follow-up visit data that was added for a symptom follow-up visit, whenever that's applicable. This is the date that the entire HUV item set is complete, including the symptom follow-up visits. And the submission of HUV data is based on this date, this ending date. So hospices have 30 days to submit their data for the HUV based on this date. In situations where there is an SFV, this date could extend beyond the HUV assessment timeframes in order to capture those 2 days that are needed for the follow-up visit. So we have a practice scenario on this item. I'll turn it back to Zinnia.
Thanks, Brenda. And this is our final one. Okay, I hope everybody responds to this one. It's the last one. The nurse visited Mrs. K on November 5th, 2025 to complete an HUV1 assessment, day 10. Mrs. K mentioned that over the past few nights, when she fell asleep, she wakes up within 3 hours and then cannot fall back asleep due to her neck pain. After further discussion with the patient while completing the symptom impact item, the nurse determines that the pain is moderately impacting Mrs. K. The nurse returned 2 calendar days later on November 7th to complete SFV. Let's go to the next slide and let's launch our final poll. So, based on HUV1 assessment of Mrs. K, what date should be entered for the date the assessment was completed for HUV1? So the correct response is B, the date the SFV was completed, which was November 7th, 2025. So remember that depending upon timing and responses to the symptom impact at admission, or either of the 2 HUV time points, the SFV can stretch beyond the assessment timeframe. Even though the SFV can stretch beyond the assessment timeframe, the HUV1 assessment can be done. So it is still part of HUV1. Therefore, for HUV time points, the date assessment was completed would be the date the HUV was completed, including any applicable SFV. Okay, now I'll pass it back to Brenda.
Okay, thanks, Zinnia. Yeah, just to clarify, because that symptom follow-up visit is actually on the HUV item set, when they make that visit for the Hope Update visit, if they need to go beyond the 2 days for that symptom follow-up, that date of completion is going to be 2 days later. So our last few items in section Z. Z0400 is a signature of the person completing the record. Again, this item is unchanged. However, you'll now complete it not only on admission and discharge, but also on the HUV time points. And this is really a tracking log for hospices to keep track of who gathered the information. It's not submitted as part of the Hope record. It's really up to the discretion of the hospice to however they manage to capture this information. And then Z0500 is the signature of the person verifying the record completion before it's submitted. And this is also unchanged, but will now also be found on the HUV time points. And this is used to document the individual that's responsible for ensuring that Hope is fully complete before they submit it. A member of the hospice staff would sign and date Z0500 to verify that the full record is complete. And I'll turn it back to Zinnia to discuss our key takeaways.
Hey, thanks, Brenda, Terry, and Teresa. Here are some key takeaways from section M, N, and Z. So Hope contains a new section, section M, which collects data about skin conditions such as rashes, lesions, and surgical wounds. Section N items that have not changed, but will now be collected at the new HUV time points in addition to the admission. And a new item in section Z is the date assessment was completed. Specifically, this is the date the entire HUV item set is completed, including any applicable symptom follow-up visits. I'd also like to take a moment to encourage everyone to review the resources available on this slide. A few of these links were provided throughout the training, and this slide also has links not mentioned but extremely valuable. Will help keep you informed and answer questions that you may have about Hope or iKeys or HQRP. And then before we go to question and answer session, we want to thank you for your time and attention. We've gone through each section of Hope and all the items. That's a lot. Most of all, thanks for participating in the practice sessions and scenarios. Okay, so as I mentioned at the beginning of the workshop, we are going to have a brief question and answer section focused on the didactic training or today's workshop topics. We received many questions previously and are prepared to answer them now. Brenda, Terry, and Teresa will help answer those questions, and hopefully many of them are similar questions that you or your team may have. And as a reminder, any questions that were submitted during the workshop will be reviewed by CMS, and these may be addressed in a future FAQ document and posted on the HQRP website. So I'll also now plug the HQRP listserv because you'll be notified when there are updates to the HQRP website. So be sure to sign up for the listserv. And then today's final slides, transcript, recording will be posted on the HQRP website, maybe in the next couple weeks or so. Okay, so what we'll do is start with the Q&As. Okay, so someone submitted this question. I recently attended a webinar that implied that for Section A, all of that information had to be entered only by the assessing clinician. The HOPE didactic training indicated that some of these items may be done by assessing clinicians. Many will be automatically populated during submission through the electronic medical record system. Can you clarify? That thing's for Brenda?
Yeah, sure. I'll take that. So for those of you who are familiar with the current hospice item set, many of the HOPE administrative items are exactly the same as you heard. Depending on your medical or your electronic health record, these can be auto-populated. There is no need, for example, for the RN to input the date of birth and the patient's social security number. More chance of error that way in general. It's also clearly stated in the HOPE guidance manual that responses to items in HOPE can be selected by the assessing clinician as part of their routine visits, or select items can be based on information documented in the clinical record and abstracted, such as the preference items that are abstracted to determine that first discussion on one of those topics on or before the completion date of Z0500B.
Thanks, Brenda. Let's go to the next one. Is it expected that nursing visits for HOPE be reported individually on hospice claims and in routine visit documentation? Terry?
Yeah, thanks, Zinnia. So, as Brenda mentioned, there are some things that have changed with HOPE and some things that have not, and nothing has changed with HOPE regarding this. So, visits should be reported as you do now for the HIS. For any questions about claims, we suggest you inquire through hospice payment policy email, and their address is hospice policy, one word, at cms.hhs.gov.
Thanks, Terry. Okay, let's go to the next question. For the principal diagnosis, can you give examples of diagnoses that fall under option 99, none of the above?
Sure, I can answer that, Zinnia. There are no examples, as this really could be anything deemed appropriate by the hospice medical director, as most contributing to the prognosis of less than 6 months. You would code 99, none of the above, if the patient's principal diagnosis is a disease that's not listed. And again, that list, we pulled that together from some very common hospice diagnoses. And I think that it bore out when we actually did the testing with the HOPE instrument. So most of those are going to fall under those conditions we have there.
Thanks, Brenda. Let's go to the next question. For comorbidities and coexisting conditions, is it required to select at least one? So why don't we see an option to select none of the above or not applicable?
So yeah, this was a question we got, I think last week, and there is no required minimum for comorbidities and coexisting conditions. Providers are expected to check all that might be appropriate, or any medical conditions that are addressed in the plan of care, or might have the potential to impact the patient over the course of the care.
Thanks, Brenda. Let's go to the next question. For HUV visits, what is the responsibility of the new hospice when a hospice patient transfers? Maybe Teresa?
I can take that. Since hospice quality reporting is at the CCN level, If a hospice patient's care transfers or changes from one hospice to another, and the two hospices have different CCNs, each hospice should complete a HOPE admission, HOPE update visit records as applicable based on the length of stay of the patient, and a HOPE discharge for the care provided to the patient by their organization.
Thanks, Teresa. Okay, on the next question, what if HUV1 was missed, but HUV2 was completed and submitted in a timely manner? Terry, could you get this one?
Yeah, so the HUV2 will still be accepted, although you will receive a warning if it's out of sequence. And then if an HUV is missed or late for any reason, for example, the HUV1 was conducted on day 17 or HUV2 was conducted on day 33, you can still conduct the visit as appropriate and submit the HUV1 or 2 record once completed, including any SFE if it's applicable.
Okay, thanks. Let's go to the next one. Does an HUV still need to be completed if the patient is in a GIP setting, general inpatient care? Can you answer that one, Terry?
Yeah, sure. So HOPE applies to all levels of care. So that includes GIP hospice patients.
Okay, great.
Mhm.
Thanks. And the next one, if a patient has symptoms of neuropathy, burning, tingling, pins and needles, but pain is not an active problem, do we still complete the neuropathic pain item? Teresa?
Yeah, I can take that. No, if pain is not an active problem, you would skip over this item for J0915, neuropathic pain. You would code yes only if pain accompanies the symptoms listed and their pain is described by the patient in that way.
Great. Let's go to the next one. So for symptom impact, are there differences between slight, moderate, and severe? Do you have specific examples of each so that coding can be applied consistently? Maybe Teresa, back to you.
The coding for symptom impact is based on the individual clinician's assessment of the patient, including interviews with the patient and caregivers. And then with this information, the clinician uses their judgment to determine the impact of the symptom on the patient. It is expected that there will be some variation in the coding for symptom impact based on each clinician's judgment. And while there are several examples in the HOPE guidance manual, the hospice staff that tested the HOPE tool did not report any issues with completing this item.
Thanks, Teresa. That's helpful. I'm going to give you a break. I'm going to ask Brenda for this next one.
Okay.
If the symptom impact screening was not done on the same day as the HOPE admission, does the SFV need to be completed within 2 days of the admission or within 2 days of the symptom impact screening date?
Okay, so this is a great question. So, in a situation where there was no symptom impact screening completed, there would be no SFV required since it's based on J2051 symptom impact to trigger the SFV. However, once the symptom impact is completed, the SFV may occur anytime within the 2 calendar days or later on the same day as the assessment, where an initial finding of moderate or severe symptom impact was determined during that admission or the HUV. So again, it's 2 days from the symptom impact, not 2 days from admission.
Thanks, Brenda, for clarifying that. Okay, I'm going to keep you on the hook here for the next one.
Okay.
What's expected of the nurse during the 2 days between the time of the SFV is triggered and required follow-up visit?
So at this time, the expectation is simply that a follow-up visit occurs for any symptom impact assessment resulting in that moderate or severe impact. The hospice clinical team is expected to be working toward managing and alleviating any distressing symptoms that are having an impact on the patient. In the guidance manual, we also note that although multiple symptom follow-up visits aren't required for the purposes of the HQRP, it is expected that the hospice staff will continue to follow up on any symptoms the patient continues to have. Yeah.
Okay,
Thanks.
thanks. Okay. For the next question, Teresa, I'm going to tag you again. Can you clarify how SFV items J2052 and J2053 would be completed at admission?
Sure. So J2052 and J2053, the clinician has 2 days to conduct the SFV if they identified any symptom that was moderate or severe in J2051. This data, once collected, would be added or attached to the admission, but keep in mind that the SFV may fall beyond the 5-day admission assessment timeframe because of the 2 calendar days to complete.
But don't go anywhere, Teresa. I'm going to ask you this next one. Since the SFV is not on a separate HOPE item set, do we leave SFV symptom impact blank at the initial assessment, HUV1 and HUV2? Do we go back to those item sets to update J2053 once follow-up visit occurs, but prior to the submission to CMS?
So, as I just mentioned, in regard to the HOPE admission, you're going to conduct the SFV only if a response to J2051 symptom impact is coded as 2 moderate or 3 severe for either the admission or HEV1 or HEV2. The SFV should occur within 2 calendar days after the initial finding of a moderate or severe symptom impact. You would want to consult with your EHR vendor for how they might add this data from the SFV electronically once it's completed.
Okay, great. All right, Terry, I'm going to ask you this one. If a patient declines the SFV when offered before 2 days are up, but the nurse follows up on day 3 or 4, should J2052 be completed with the later date or note that the patient or caregiver declined the SFV?
Yeah, so if the patient and caregiver decline the SFV, J2052A should be coded as 0, no, and J2052C should be coded as 1, patient and caregiver declined an in-person visit. And even if the nurse visits on, say, day 3 or 4, J2052 would already have been completed, and the 2 days allowed for the SFV would have already passed.
Okay. Okay, Brenda, I'm going to ask you this one. What happens when the SFV extends beyond the assessment window for the admission or HUV time points?
Sure.
This-
We did mention, depending on the timing and the responses to the symptom impact item, the SFV could stretch beyond those specified times of 0 to 5 days, and for the HUV on or between days 6 and 15, for example, since the clinician still has 2 days to conduct that follow-up visit. So, for example, say that on day 15, the nurse gets to do that HUV1 and she identifies the symptom impact, then she might provide some medication, get some orders, put them in place, and she might visit again on day 17. And in that instance, that 2 days beyond would be when you were going to date that ZO350 date assessment was completed, would correspond to day 17, because that's when the entire HUV was completed, including the SFV.
Thanks, Brenda. Okay, I think we have time for just one more question here. Terry, I'm going to have you answer this last one. For hospice patients who reside in a facility, does the hospice RN need to complete the skin assessment for HOPE, or do they need to use the one done by the direct care facility staff?
Yeah, so in order to complete the skin assessment for HOPE, the hospice nurse should conduct their own assessment. Should there be any discrepancies, the hospice nurse should discuss them with the facility nurse, and doing that will ensure that the most accurate and up-to-date skin assessment is reflected in HOPE.
Okay, great. I think those are all the questions we have time for. So thank you, Brenda, Terry, Teresa, for the training and addressing the questions today. Thank you, too, to all the attendees that submitted questions during the workshop. And as I mentioned, those questions will be reviewed by CMS and may be addressed in a future FAQ document and posted on the HCRP website. So congratulations to all the attendees for completing the workshop and staying for the Q&As if you're still here. So at this point, I'm going to turn it over to Alana to wrap us up.
Great. Thanks, Zinnia. And thank you, everybody. Before we wrap up today's workshop, a quick reminder, a survey will automatically open in your web browser once the session ends. We'd really appreciate it if you could take a moment to complete it. Your feedback is incredibly valuable to us. Thank you for joining us today, and we hope you have a lovely rest of your day.